Okay, hi everybody. So I'll try to give you today a perspective on child abuse that is coming from a physician or a pediatrician, as I am a pediatrician first of all, and just take you a little bit to a little tour. So first I'll talk about Da Vinci, who said that people usually are categorized into three groups. The one is those who see. This is a very, very small group actually. The second is people who see something after you show them, okay? And it happens to us all the time. I mean, if I buy a new car, then suddenly I see this new car all over. Before I didn't see it at all. So after I'm accustomed to see something, I see it more. And those who never see it, which is a very, very small group. So with child abuse, I'm in this middle group that after I was shown child abuse, I started to see it more and more. So as physicians, and we talked a lot about physicians' eye, we were taught that if we take a careful history and examine our patients, and then maybe send some labs or other stuff, we'll have a diagnosis, and then we can treat them. But when it comes to child abuse again, this is not it. We're not told the story. Many times we don't see anything on the physical examination. And then when we do the lab tests, we get nothing. Now, this is a picture of a patient with lupus. Lupus is an autoinflammatory, autoimmune disease, which is very uncommon. But as a medical student, I got something like 1,000 hours learning about lupus. And till today, I've been a pediatrician for now maybe 15 years. I've diagnosed already 3 patients with lupus. So we have a lot of energy directed in the wrong directions. And about child abuse, I was never taught, not during my med school, and not as a resident in pediatrics. They used to say, you know, there are kids with subdural hematoma. This may cause restlessness. So it isn't that they have differential diagnosis of restlessness, subdural hematoma. But what I was never told is that these subdural hematomas, they don't come from heaven. They come from the sky. They come from a child being manipulated, being metultalim, shaken. Yeah. Yeah. So again, as doctors, we really, really love blood tests, you know. Why do we love blood tests? Because maybe I have a patient, maybe it's a 12-year-old girl, you know, and she's a little bit pale, and a little bit tachycardic, and she says she has difficulty breathing when she exercises. And when I check her, she's really pale. Then I send a blood test, and it comes back that she has anemia. And I'm saying, yes, now I know what she has, and now I can give her maybe treatment. And that's it. It's really good. And with other patients, a patient may come with fever. And he says he has chest pain. And I'm listening, and I'm hearing he has something on his lungs. And then I'll send him to a chest x-ray. So this is the normal chest x-ray. When I send this guy to the next chest x-ray, he has here this spot. You see this spot here? This is pneumonia, okay? So we really like to do diagnosis. And we like to do that because it gives, you know, it's nice to have a diagnosis and then give treatment and then see your patient getting well. But this is not the case in child abuse. I cannot see a child abuse patient in my office, do the diagnosis, giving the treatment by myself, as I'm accustomed, and then send him home and know everything will be okay. This is not the case. So we like to diagnose. So I was not taught about child abuse, but then I started to realize that many of my patients are not being treated. I'm not treating my patients. They're coming with problems that I don't know how to solve, but I don't know they are there. And one of the things that hit me is the extent of child abuse. It's because we were never told that it was so extensive. And it was maybe, you know, girls are being child sexually abused, but boys aren't. That we know it's not true. And fellow pediatricians would say, no, you know, child abuse is something that only happens there. It doesn't happen here. It's over there somewhere. It's also not true. So when you look at the children in Israel, with Professor Lev's Triana initiative, so I won't cite the numbers, just skip on and see how prevalent it is. And when Rachel first showed me these numbers, I thought that, well, if you have a phenomenon which is more than 50%, this is like physiology, you know? This is what happens to everybody. We need to start rethinking what we're doing. So look at the exposures for abuse for children and adolescents. The numbers are really huge. And it's true for emotional abuse, sexual abuse, physical abuse and neglect. And all of these people are coming into our medical sites, okay? They're coming to my ER, and I'm not treating them. So what am I treating? If I have so many patients who I'm not treating, as a physician, I have an obligation to treat my patients, and I'm not doing that. Okay, so again, when we talk about sexual abuse, we're thinking, okay, the numbers are really high. This is probably, you know, each girl that someone just touched minimally, she's saying she was sexually abused. When we look at the harsh abuse, the numbers are really high again, okay? Sorry. This is harsh abuse out of the total of sexual abuse. It's almost half. Okay, for physical abuse, these are the numbers. These are children that were hurt in a way that they needed medical help. I mean, they were in my ER, right? They broke their hand, or they had a huge ulceration and stuff like that needed treatment. It's not like a little slap on the cheek, something like that. And these are the reports from the medical system. Okay, so you can see that the number of reports is really, really low. We're talking about something like, in children, something like a total, of 3,000 a year out of all of the children in Israel. That means that a lot of children, and children will come to the healthcare system when they're healthy and when they're ill. All children in Israel will come into the healthcare system. I mean, we see everybody. So we are under-diagnosing child abuse. Another thing is that many of the times when we diagnose child abuse, it's really late. You know, when we talked about disclosure before, so for child sexual abuse, the disclosure age is around the 20s, okay, 20s, 30s, and we see a lot of patients that are, the first time they talk about being abused as a child is in their 40s and 50s. Some of them went through a lot of treatments, okay, they've seen a lot of doctors, they've seen a lot of psychologists, psychiatrists, whatever, but no one has directly asked them, have you ever been abused? No one. Because people don't really, at times, feel that they can hold the answer when they get the answer back. So what I'm trying to say, we want to catch or find or diagnose these children when they are children. I don't want to diagnose someone when she's 50 or someone when he's 50 because he had like 40 or 50 years of suffering, which I couldn't, his general condition was lower than it could be had he been treated during all of these years. So how can we find them? We had a big question. How can we see? We see the kids, they're not talking to us, they're not telling us. How can we diagnose them? How can we find them in this surrounding? So I was looking at my numbers and saying, okay, in my pediatric ER, we have 2,400 children arriving each month. So I need to see, or I'm supposed to see, something like 400 children who have been sexually abused a month, okay? And 340 that were physically abused, and 340 cases of neglect. But what do I actually see? So after going through a big process, we're only diagnosing now one child a day, which is a lot. It's something like 360 children a year. When we started the process, we were looking at files, looking back. And we had like a case or two a year, okay? When you started the process, we had a case or two a year. That means no diagnoses of child abuse at all, or almost at all. It was just like accidental. So we need here a conceptual change. And the conceptual change is that child abuse is not something, a sociological problem, or a psychological problem, or a problem that happens over there. We need to say clearly that the child abuse is a disease. We should call it a disease because we need to treat it as a disease. And this disease carries in it mortality and morbidity. It carries direct mortality. Someone is hit enough to die, okay? Indirect mortality from depression, from early cancer, from early diabetes, and other diseases. And it's really like a malignant disease in many ways. It's like a malignant disease because it takes a multidisciplinary team to treat. It affects all areas of life. And it affects the whole surrounding. And many times we look at it as a multiple casualty event. Because parents may come with the child and will reveal his child abuse. But they're going to be hurt in the first circle also, and the second circle. So we see that a lot. So I'll give you a case presentation that will clarify a little bit of that. So we have a 19-year-old that her chief complaint is injury to her knee. She's coming, she's a soldier, and she's in training, and she hurt her knee. So she hurt her knee, so they sent her home with a cane so she can rest. She comes home, and her mother picks the cane and starts hitting her in the injured knee. And then she comes to our ER and says, listen, my knee is hurt. This time she wants to say, my knee is hurt because my mother attacked me. I don't want to go back home. She's already 19. She's a grown-up. And then she has to see a social worker. And then when the social worker comes, she tells her, you know what? I met you a few years ago. I came here with another injury. I came by myself. And since you cannot release a person home when he's underage, so they called the social worker. They had a nice talk, and she went home. And the story is that during her childhood, on many occasions she's been hurt by her parents, but her mother was a nurse, so most of the time she treated her at home. She used to fix her lacerations, suture her, cast her, etc., at home. So we went back and we started to look at her meetings with our medical system. So she was in the orthopedic ER, on the general ER, all time with injuries, and she was practicing judo. So every time she came, she said, this is from judo. No one asked her exactly what happened. And we know we joke about orthopedic surgeons that if they elaborate, if they want to just, they say an injured arm, and if they wanted to elaborate, they say an injured ulna, which is one of the bones in the arm. You know, they won't say, they don't ask more than that usually. We need to ask children, how did this happen? And most of the time, they'll speak very clearly about what happened to them. And if they're not, you should be suspicious, because a child will know about his traumatic experience. So we see all of these. One of the things we should look at, we talk about attention-detention disorder. So at the age of around 14, she has a neurological counsel, and she's starting to be treated for ADHD. She started on Ritalin, on amphetamine. And just for basic knowledge, amphetamines are really not good for traumatized patients as a baseline. But she was done that. Other times she met with an eye doctor and community clinic. And she has really good pediatricians in her clinic. I know them. A really good pediatrician, but no one has ever asked her directly or thought about it. Now I have to say, and as doctors and also as everyone who treats people, when we are educated, they tell us, listen to your patient, but don't listen to your patient and think, maybe he's not telling me the truth. Or maybe he's not telling me the whole truth. I'm not suspicious of my patient. When someone says, I have chest pain, I go, okay, you have chest pain. I don't think he's telling me he has chest pain, but actually he has a knee pain. No, if he has chest pain, he has chest pain, okay? But when you try to deal with child abuse, you need to reset your mind and think more clearly about what you're hearing and what you're not hearing. So we have here a lot of opportunities in this case that we can learn from. So a chief complaint of injury is not enough. We have to know exactly what happened. We need to ask our patients, and I talk to 3-year-olds and they talk back, you know, because usually the parents barge in, but you should need to talk to your patient. We should do thorough examinations because maybe his finger is hurt, but I'll see signs on other parts of the body. When I see other signs on the body, I need to get more comprehensive history. I need to go back and take the history again and think again about the history. A new diagnosis of ADHD is always a red flag for me because usually patients with ADHD start really early in their life. If a 12-year-old studied very well until now, and now he has ADHD suddenly, then something else is bothering his attention. He has an attention disorder, but something else is bothering his attention, and it's not a psychological thing. And a child arriving alone is always an opportunity to speak to the child and understand, because most of you as parents know that if their child is injured, they'll come to the hospital. This is the norm. When someone is out of the norm, just think, why is he out of the norm? Maybe his parents are abroad. Okay, so they're abroad, you know, you have the story. But maybe they're not. Maybe they're here and they're not coming. So what are the restricting factors? Why are we not thinking of it? Why are we not trying to deal with it? Why are we pushing it away? There's always a fear of false allegation. Because we did not get the story most of the time, or many of the times, we're afraid that we'll say something which is not exact. But I have to say, many cases, you know, like we have a child with a lot of fractures, okay? So my colleagues would like to have him to have, my physician colleagues, they'll think of osteogenesis imperfecta. Osteogenesis imperfecta is a metabolic bone disease which causes multiple fractures. But this is extremely rare. Now we have here 2 conditions. One is extremely rare, and the other is extremely common. So let's go for the extremely rare. It's like, you know, if you have a patient with fever and a cough and a chest pain, and the chest radiograph I showed you before, you say he has lupus. No, he has a bacterial pneumonia until proven otherwise. He may have lupus. But the odds, if you look at the odds, most of the time, 99.99% of the time, it's pneumonia, it's not lupus. And it's the same with abuse. Many times we're looking at it, but we don't want to think about it. So let's find him something else which I like better, which I know how to treat. Okay? I don't know how to treat child abuse, but I know how to treat a fracture. I'll treat this fracture. Forget about the abuse. There's a betrayal of trust. I talked before that most of the time when our patients come, we're not thinking, oh, he's not telling me the truth. But when I think about it, when I even start to think about it, this is one of the things that was most difficult, at least for me. Starting to think to myself, maybe I'm not getting the truth. Only shifting and thinking about it is distressing. It's much easier to take things as they are. And there's a betrayal of trust for the patient, and you're afraid of a betrayal of trust between the patient and his parents, and the child is our patient. The child is our patient and not his parents, and it's always complicated. There's a fear of damaging this attachment. We talked about before that when a child has to choose, he'll choose the attachment and not go against his parents. He'll rather be hurt, he'll rather be abused, he'll rather be raped than breaking this attachment, because the attachment is like, I don't know, water and air. You have to have that in order to live. You need this attachment. It's much stronger than any other feeling. The other thing I hear a lot from doctors, from the same doctor usually, in a 5-second difference, is that the authorities won't do anything. They don't do nothing. A second later, they'll take the child and remove him from his home. And what I learned through the years, it's not black and white. It's usually in the middle. They don't do nothing, and they don't take children, most of the time, they don't take children out of their homes. Maybe sometimes they should do it more, but they don't do that as an automatic thing. And they have a lot of, we have in our society a lot of, resolutions, other solutions that may be brought to them. What also happens with physicians and child abuse that it's really easy to follow a patient with pneumonia. But it's very hard to follow a patient with child abuse because he goes out of the medical system most of the time. Okay, after I did the diagnosis of abuse, he'll go out of the medical system, and the interaction is really weak as it is now. And another thing is being lonely. Because if I'm going tomorrow to see my fellow doctors at the morning meeting, you know, and I say, look, I was suspicious this was lupus, and I nailed it. It is lupus, okay? Everybody will want to hear about it, about everything, about the labs, about what was in the physical examination, what did I hear in the history, etc. If I'm coming at the same morning, I'm saying, listen, I nailed it. This is child abuse. They're like looking at me like, he's crazy. This guy is crazy. He's thinking of abuse all of the time. It can't be. It's only a bone fracture. It's not abuse. He's imagining. Because we'd rather have a different diagnosis, a nicer diagnosis. And if we don't get a story we like, that many people will change the story. Okay? They'll tell the parent, you know, something really, really similar happened to me, and stuff like that. So we have other biases. One of the major biases is a socioeconomic bias, about the socioeconomic study. If someone is coming, who is a new immigrant from somewhere, he's very distant from me, it's very hard it's very easy to say that this may be abuse, okay? The further he is from you, it's easier to say it's abuse. The closer he is to me, okay, I live in Mazkeret Batya, which is next to Rehovot, okay? If it's a physician from Mazkeret Batya, and his son will come, you know, with an iron sign on his body, no one would think of abuse, okay? But if it's a new immigrant from somewhere who came here to work, and his child is coming because he's sneezing or something, this may be abuse. Okay, then they call me for a consult. So we have a very, very strong bias. A second bias is our personal experience. Because we'd like to hear a story we'd like, so if I see someone with a laceration, I'll think, oh, this happened, something similar happened to me when I was a child. I remember I fell and this, but you weren't told this story. And you have to listen and to hear the story you do hear, and not the story you want to hear. When we're a parent, this even is more exaggerated. If you're a parent as a caretaker, as a physician or a psychologist or whatever, then for many situations you say, this can't be because as a parent, I'm not doing that, okay? I'm not hitting my son, so he may not hit his son. Because people do not hit their children. But on other fields, you don't have a problem to see that there's a big difference between you and others. You may be vaccinating or not vaccinating your child. You may be being a strict vegetarian at home or not. Saying you may be religious or not. And you don't have a problem to see that others are treating their children differently. But when it comes to abuse, people are always coming back to, I wouldn't have done that, so this doesn't happen. So we always prefer a different medical diagnosis, other than abuse. As rare as it may be, I'd rather choose that and not abuse. So what we see, so we started to think, how can we find these children? They're coming here, but not telling that they were being abused, and most of them don't have physical signs, okay? Most children don't come with an iron sign on them. They'll be treated at home most of the times, or not treated at home. So the medical profession and other professions will meet these children on many occasions with other things, with headaches, with suicide attempts, with abdominal pain, with myalgia, with the muscle hurts, with cell injury, with shortness of breath maybe, with syncope, that they faint, or with urinary retention, with many, many, many aspects. And these kind of children will see a lot of doctors. With the abdominal pain, they'll go to a gastroenterologist, and with urinary retention to a nephrologist or a neurologist, and with shortness of breath to a pulmonologist. They'll see a lot of doctors. But at many times they come, I see these children and they've seen like 6 specialists, but no one yet looked at them as one piece. Okay, this is one child who has all of these complaints. And what physical diagnosis could do all of these things? And many times the answer is child abuse. Okay? So this is the root. And until you start treating here, you'll continue to have fruits, because you may do, I don't know, give painkillers for the headache, okay? And for the shortness of breath, maybe teach him do some CBT. But when he's done with his shortness of breath, he'll start doing self-injury. So it goes from one to another. So we like to divide it into physical aspects and psychological aspects. But actually it's more of the same. What we do see is that smaller children, 4, 5, 6 years of age, will come more with the physical things, because it's easier to diagnose them or to hear about them in these kind of ages. And the older they get, they tend to be more on the psychological / psychiatric part of the map, okay? They'll come with sleep disturbances, depression, anxiety, self-injury, outbursts. And as smaller children with headache, abdominal pain, encompresses, enuresis, etc. So children basically don't want to tell us the story. We've talked about it. They don't want to tell us. Who wouldn't you tell? A physician or a social worker or another kind of therapist. These are who could you tell. So they're not telling. So what are they saying? What do they say? We're saying they're not telling. What do they say? So Shir brought along the listening guide. We started to use it as a tool for research. Carol Gilligan's listening guide, yes. As a tool for research. But the more she talked about it, I started to think, maybe we should change the way I listen. I saw she's changing the way she's listening to children. I was thinking, maybe I should change it also. Maybe you can listen differently and then get information you may not otherwise get. So what did we learn from the listening guide up to now? We're starting a research about it also, but what did I learn from the listening guide? What inspiration? Now, many times people will talk in an I voice. I is when I'm talking about myself. And in a you voice, when I want to distance something, I talk in you. And in Hebrew, it's more distinct because we have a you for a female and a you for a male. So when a female talks with a male you, which this is the dominant use, so we need to think, what is said in I and what is said in you? What does she want to push away? Many times children will say, I don't know. Now, I don't know is composed from I know. Don't look at the don't. When a child says, I don't know, it means I don't want to tell you maybe, but I know. Okay, so you'll hear it a lot. I don't know. So you can ask him, what do you know? And sometimes they tell you what they know. We hear changes in tone. When someone goes from into and out of dissociation, you'll hear changes in tone. They start whispering, or starting a different kind of voice, a kind of childish voice. You see a teenager talking like a baby, with baby talk. Many times, children react well to the word really. Now, it's very difficult for a child not to tell you the truth when you say really. It's more difficult. So we use really. What really happened? I see you've been injured, and I don't understand how it happened. What did really happen to you? So we may answer, when he says really, he means really. This is what really happened. Okay? We're talking about the body speaking, so the body speaks in many ways. One of the ways it speaks is with the complaints, the somatic complaints. So when a child may point to the parts of the body that ache. And you always have to think about, I was told here a story, what wasn't told? What gaps are in the story? About what parts the child is not speaking when he's talking to us. Give another case presentation. We have a 9-year-old, and she's thought to have been, her brothers have been abused, and she's taken out of the home. But she was never interrogated and never checked. And her physical exam is normal. Also, genitalia is normal. But I'm thinking she looks dissociated. So what we do now, that we've created a new questionnaire, which is the medical somatic dissociation questionnaire. We'll talk about it tomorrow. But this is kind of a very nice screen to have in order to, when you think about child abuse. We've talked about screens before, so this is a screen you may start using. Because what we find in adults that when it's positive, it correlates with child abuse. It correlates very, very strongly with child abuse. It has been validated also in children. So I do this kind of somatic dissociation questionnaire, and it's positive. And then I ask her for a self-portrait, which is another tool that we're kind of using. And she draws this kind of picture, okay? Now, she's about a 9-year-old. When you look at the picture, it doesn't look like a picture a 9-year-old would do. This is the first thing that jumps, okay? Now, when I ask a person to draw himself, he should draw one figure. He may only draw the head, or he may draw the whole body. But he will usually use only one figure. In here, you see at least 4 figures, okay? I see more, because this kind of gibberish here is also figures, okay? And here. And she says, you know, she's very talkative. She can't stop talking, you know. So she's saying, you know, on one side, I have Satan. And on the other side, I have an angel. And you should listen to the angel. You, in a male voice, should listen to the angel. I'm thinking, what might this angel tell me? And she also she puts here a lot of hearts. You see here kind of hearts. Yeah, this is something we saw with a lot of sexually abused children, that they draw a lot of hearts. One of the thoughts was, this is for all the times that they were told that how much they are loved. So they show us this love. So clearly you can see here dissociations because we have a lot of figures. And we look at the hollow eyes here. This is another sign for child sexual abuse. So clearly this child also needs treatment for child sexual abuse. It won't be helpful to send her just for, you know, small talks somewhere. She needs someone who is an expert in child abuse to treat her. This makes a big difference later. Now, when we catch these children when they're 8, they won't necessarily have symptoms when they're 40. But if we skip them, they're going to suffer a lifelong disease, okay? So what is the system that we use? Not really briefly. The system we use is called we call it the red flag system. But anyone working in the hospital or in the community can raise a red flag. After we raise the red flag, we start internally looking at it. So we have a physician, a nurse, a social worker, the educational service inside the hospital, a psychiatrist as needed, and other hospital staff. And we think about the case and start to think what we should do about it, how should we go on about it. But one of the things we've developed is that in this inner circle, we've created a common language. We write in the same way. We'll talk about it later this week. We write the same way. we adopted the way in which the nurse, the social worker, and the education service, we talk in the same language. But when we go outside of the hospital, because of the uni-disciplinary stuff, so each one will talk to counselors or the community I'll talk to the community pediatrician or the medical counsels, and not the social worker. Okay, so we can speak in the same language, then I translate it into the common language. The same about the nurses, social worker, that will talk with child protective services, the police, okay? But they have a common language, and what I found is when I'm trying to talk to child protective services, these are not good talks, okay? I'll just summarize it. Not good talks. I shouldn't talk to social workers working outside the hospitals. Many of the times it wasn't good for both sides. And again, educational services, with the education system, psychiatry, with mental health services, etc. So what are the roles of the child abuse pediatrician, just to summarize? Detection of abuse, taking the medical history, doing the physical examination and the forensic examination is needed. We should rule out the differential diagnosis, especially when we're going to court. You have to rule out the differential diagnosis. Should be part of the holistic assessment in the multidisciplinary team, and give your part as a pediatrician. I give my part as a pediatrician. We do all the counseling and counsel others. Because if the main problem of the child is abdominal pain, I don't start with child abuse. I listen, okay, it may be child abuse, but first of all, let's rule out other common pediatric diseases. At the end, we do the diagnosis of the abuse with the team and start treatment. And part of the treatment, part of the beginning of the treatment, is listening to the patient, taking the history, but really listening to them. Because many times they'll come back later and say, you're the first person in the system that really listened to me. Because you've listened, I could have told you. And this moment is a life-changing moment. And they come back later and say, you know, this was the life-changing moment when I came here and someone listened to me. Independent, so this is part of the treatment actually, okay? Listening. Other part of the treatment is taking someone who was sexually abused, checking him. Most of the time, he wasn't injured physically, but he needs to know that, okay? Children have fantasies. They sometimes think that something is broken or beyond repair. And if I check a girl or a boy after being physically hurt or sexually hurt, and I tell him, and this would happen most of the time, you're okay, you know? Your genitalia is okay. It's functioning. It's okay. It doesn't need any kind of treatment physically. Doesn't mean you don't need treatment, but physically you don't need your treatment. So this is really important for the whole process. Okay, thank you for listening.